Good evening, everyone. Welcome to today's CPD session on thyroid disorders in primary care, organized by Sri Lanka College of Specialist Family Physicians. It's great to see such a large gathering of professionals who are eager to advance their knowledge in this important area of primary care. Already 165 has joined. It is my pleasure to introduce our resource person for tonight's session, Dr. Dulani Kottahachchi. Dr. Kottahachchi is a highly accomplished and well-known consultant endocrinologist and a senior lecturer at the Faculty of Medicine, University of Kelaniya. I'm sure all of you know her. And if I mention a bit about her, she has obtained her MBBS with a second class upper division and multiple distinctions. And she was ranked 10th in the National Merit Order of that year. And Dr. Dulani Kottahachchi obtained her postgraduate studies at the PGIM University of Colombo. And she also completed an honorary fellowship in endocrinology at the Alfred's Hospital, Melbourne, Australia. And she is a board certified specialist in endocrinology. In addition to that, she is a member of the Royal College of Physicians as well, Royal College of Physicians UK as well. And her contribution to scientific research and academia have been recognized through numerous honors and awards, including the Presidential Award for Scientific Publication and multiple awards for oral presentations, and also for her excellence in teaching and research supervision. So, before we begin, please allow me to remind of a few housekeeping rules as well. Please mute your microphones unless you need to speak, because we need to minimize background noise. And if you have any questions, feel free to post them in the chat box. They will be addressed during the Q&A session at the end of the lecture. Also, the attendance will be recorded for the CPD points. So please make sure you remain throughout the session, and the session will conclude with a brief feedback form. You have to fill that feedback form to obtain the CPD certificate. So I hope you would have an informative and engaging experience today. So without further delay, let's welcome Dr. Dulani Kottahachchi to begin her presentation. Thank you. Over to you, madam.
Good evening, everyone. And first of all, I would like to thank the Sri Lanka College of Specialists in Family Medicine, Family Physicians, especially Dr. Deshan Kottugedalla, my dear friend, for the invitation. I would like to thank the college for selecting such a common topic. But although it's a common topic with lots of problems in management, I think we've learned about thyroid from our university days, medical college and postgraduate, but still all of us face numerous problems in managing these patients. I think one, because of the complexity of the diseases, their presentations, the investigation, especially the investigations, interpretations, and the management of the diseases differ. So my focus today is to talk about the main thyroid disorders which we encounter in day-to-day lives in our clinical practice in primary care. So if you have any questions, you can raise it in the middle also if you want to, and ask questions. And let's start the presentation with a case. My first case is going to be a very common presentation, 35-year-old female coming with complaints of hair loss, weight gain, dry skin. She had a family history of thyroid disease. Her mother had a history. She's married, but she has completed her family. And she has a BMI of 28. And on examination, she has a diffuse goiter. So when we investigate for one of the commonest investigations we do for weight loss, weight gain and hair loss is thyroid function tests, apart from doing probably a full blood count as well to make sure they're not anemic. So the TSH in this patient is 25. We can see it's above the upper limit, and T4 is quite low. Let me first highlight the investigation here as well. When somebody comes to you with weight gain and they complain, one of the things, as I said, we would do a TSH. But the subclinical, which the TSH kind of below 10, are very unlikely to be the reason for weight gain. So if you are focusing just on that, you might miss to treat her obesity, her dietary modifications, exercises, thinking that the TSH is the cause for weight gain. So weight gain usually occurs in TSH above 10 and usually is about 5 kg, not more than 5 kilograms are usually for thyroid diseases. So make sure if you have a very overweight patient, they might have a marginal higher TSH, because TSH levels also have a bigger variation. It can be even quite low, marginally quite in the suppressed levels as well in obesity. So don't get misguided and treat them just for a hypothyroidism, but treat them for obesity as well. But this patient, you can see obviously it's about 25, it's above 10, it's a 25 TSH, showing that she has a primary hypothyroidism. That is the diagnosis, and this patient is quite straightforward, but let me tell you how we manage these patients as well. So how do we diagnose thyroid dysfunctions? When you do a TSH, it could be high, it could be normal, it could be low. So if we find a higher TSH, we would do the T4 levels, but not in all cases. We are not, equally having the benefit of doing all T4 in all patients because of the cost. But if your T4 levels are low, with a higher TSH, this patient is having hypo or overt hypothyroidism. If your patient's TSH is usually above 10, we said overt, and if the TSH is less than 10, with a normal T4 levels, we call these patients are having subclinical hypothyroidism. So just above the normal upper limit, let's say upper limit is 4.5, above 4.5 to 10 is subclinical, but they should be having a normal T4 levels for us to say subclinical hypothyroidism. If your patient's TSH is low, when we do a T4 levels, if the T4 is normal, we call these patients subclinical hyperthyroidism. So let me highlight this point. I have seen many patients just being diagnosed based on a TSH, low TSH, as having hyperthyroidism. Never do that, because there are so many causes for lower TSH. Just by looking at a TSH, you can't start on antithyroid drugs, you can't come to a diagnosis. Please don't do that. Wait for your T4. And if your T4 is normal, you can, if it's highly suspicious, you can go and do the T3 as well, to rare cases of T3 toxicosis. If the patient is not symptomatic, that patient is having subclinical hyperthyroidism. So most common reason for subclinical hyperthyroidism is probably having a goiter with mild nodules. They can have high low TSH, but normal T4, T3. So we don't treat them with antithyroid drugs unless they are really, really symptomatic, but that's also with a normal kind of a very low dose. Only if your patient's TSH is low with high T4, then we diagnose these patients to have hyperthyroidism. Wait for your T4 to make the diagnosis. That is very important. Just don't make any conclusions by looking at a TSH. Wait. You can treat them symptomatically with a beta blocker if they're symptomatic, but still, I would ask you to wait for the T4 for the diagnosis. So there are three main types of hypothyroidism: primary, secondary, and tertiary, as you know. So primary is something to do with the neck, the goiter, is the problem is in the thyroid. If you have a secondary hypothyroidism, problem is due to lesion in the pituitary gland, a tumor, a craniopharyngioma. If you have a tertiary hypothyroidism, that is due to a lesion in the pituitary stalk or hypothalamus. So depending on the site where the problem is, these three patients are all present with the same symptoms, but their investigations are going to differ. Because in primary hypothyroidism, you would see a higher TSH, and the patient will be having low T4. But in central, you will see the TSH being low with the T4 being low. So one of the causes for having low TSH, low T4 is secondary hypothyroidism. So commonest we see is the primary hypothyroidism, and one of the commonest is the congenital hypothyroidism in children. That is due to agenesis of the gland, and they can be having some defective thyroid hormone biosynthesis due to enzymatic defect. And secondly, we see the commonest we see is due to destruction of the gland itself, commonly due to Hashimoto thyroiditis, that is a chronic autoimmune thyroiditis, due to radiation, after radioactive iodine treatment, after doing surgery, thyroidectomy, and they could be having some infiltrative diseases like hemochromatosis. They are common as well, but not very common compared to Hashimoto's thyroiditis. That is the most common cause of primary hypothyroidism. And there are some drugs which can have an effect on the thyroid, like lithium, iodine, iodine-containing drugs, radiographic contrast agents, and interferon alphas as well. So these are some of the secondary and rare causes of hypothyroidism. So it depends on your clinically situation when we think about this. So as I said, hypothyroidism due to chronic autoimmune is the commonest cause. So how common is this? So mean incidence of hypothyroidism in women is mostly due to Hashimoto's and is about 4.1 per thousand annually. And women are about 8 to 10 times more commonly affected than men. And it's more common in Asians and European people. So it's commonly we see in females. A bit about Hashimoto thyroiditis, we call this name. Why this name? This was first described over a century ago by Dr. Hikaru Hashimoto. He's a Japanese scientist, as stroma lymphomatosa. And these are the synonyms we use: chronic lymphocytic thyroiditis, chronic autoimmune thyroiditis, lymphomatoid goiter. There are some FNSE reports, some ultrasound scans, they talk about this. And so these are synonyms we use for the autoimmune thyroiditis. What are the types of this Hashimoto's thyroiditis you see? The commonest we see is the one with a goiter. This is called classic goitrous. The gland is firm, pocillated, and they could be having hypothyroidism or not started to have hypothyroidism. So all goiters you see, let's say you see ultrasound scan, you see your goiter, you did ultrasound scan, and it shows a bit of enlargement of the gland, echo texture being heterogeneous, sometimes vascularity increased. But you do a TSH, T4, it's completely normal. This patient is not having hypothyroidism at present or even hyper, but the gland is not normal. So what we do in these kinds of patients, we observe them like probably 6 months, depending on the TSH, or yearly, because their gland is not normal. It might get activated, might not. We can't say. If you do antibody, yes, you can probably guess, but still then don't treat just for a goiter without having any symptoms or biochemical or features of hypo or hyperthyroidism. The second commonest we see is non-goitrous. That is, there is no goiter, there's no enlargement, and it's normal thyroid gland, but they have a tendency to hypothyroid. They could be having marginally raised TSH levels, but still you could see in ultrasound scan or clinically the gland is not enlarged. The third one we see is an atrophic thyroiditis. There's no examination doesn't show any gland. Ultrasound says a small gland, the fibrous variant, the atrophic thyroiditis. So these patients obviously have hypothyroidism because the gland is non-functional at this point. So patients who are detected with a goitrous, the hypothyroid, it shrinks gradually. So later on, you will not, when you examine, the goiter will probably disappear because it has shrunk to the nature of the disease itself. So what causes this Hashimoto's thyroiditis, and bit of pathophys on this? So this is when you have antithyroid antibodies positive, especially the antithyroid peroxidase antibody or TPO. That is, we detect in serum. So what causes this? With genetic factors, when you have very close relatives having positive antibodies or thyroid diseases, you could be having, you have a high chance of getting this. And even some environmental factors like iodine intake, infection, smoking, pregnancy, certain drugs are shown to have proven to have a higher tendency for hypothyroidism. What happens is we lost the immune tolerance to thyroid cells, which leads to production of antibodies against your own thyroid tissue, and we destruct the thyroid gland by ourselves because we lose this immune tolerance of these thyroid cells for these antibodies. That is why when you have antibody positive, it's not always have not activated and destructed the gland. Still you would have a normal TSH for some time. That's why we need to observe without treatment if they have a normal TSH. So clinical features of hypothyroidism we've learned from physiology, medicine, all that. I think it's common symptoms. But the problem is these symptoms are common to so many other diseases. When somebody says, I have weight gain, I have I'm feeling tired, I'm feeling constipated, I have cramps. You can think of so many differential diagnoses. So I think when somebody sends me a patient with hypothyroidism, I'm sometimes intrigued by symptoms. They have just done a TSH. How wonderful our primary care is, physicians is, what I see in the GP practice also detect subtle symptoms. They have thought of hypothyroidism. So I think it's quite good to have such intrusive brains thinking about this. So the common symptoms we see, as I said, there could be severe hypothyroidism, puffy face, they lose their eyebrows, they have a goiter, they could have effusions, ankle edema, weight gain, constipation, cramps are a common symptom, fatigue, they can have bit of depressive symptoms, slow speech, bradycardia, pericardial effusions. They could be having hypertension, irregular or heavy periods, loss of libido, subfertility, and brittle nails, paresthesia. These are the common symptoms we see with hypothyroidism. And the commonest we see would be going into the fatigue, tiredness, cramps, and weight gain, as I said, but it's always more than 10 of TSH, which causes weight gain. As I said, often not specific, but appear gradually and become severe when it progresses without the treatment. So you can see in this picture, patient before and after treatment. Look at her face, the puffy face has reduced. Her lips, you can see they are kind of dry, they are enlarged. You can see how nice. And her hair looks very brittle there without treatment. So like that, you can see the change you can make when you make a good diagnosis in endocrinology. So what are the clinical variants we see? The commonest subclinical hypothyroidism, because even in pregnancy, we see the Hashimoto's drug-induced in children, juvenile, and silent and postpartum autoimmune thyroiditis as well. So how do we investigate? We do the antibodies. So when you do the antibodies, you have to remember the anti-peroxidase antibodies or anti-TPO are the commonest. So if you see a positive antibodies, like 90% of the time it is due to Hashimoto's. But if you do thyroglobulin antibodies, about 10 to 20% of the normal population has positive antibodies. So don't waste your money on thyroglobulins. If you just can do one test, do the anti-TPO peroxidase antibody for diagnosis. And this diagnosis, you don't have to do in all patients. It's a very expensive test. If you have all the clinical features and if you have the biochemical evidence, you can start. I will tell you later when we should be doing antibodies in our clinical setup with poor resources. We can't be doing antibodies in all patients, but this is commonly done in all other countries, especially the Western countries, for all evaluation of patients. So when you have subclinical hypothyroidism, as I said, you have a raised TSH, normal T4, T3. Overt hypothyroidism is a raised TSH more than 10 with low T4 levels. So what other investigations should we do in this patient? Should we do ultrasound scan in all patients? No, we should not regularly do this. We first should examine for any thyroid nodules. If you have a suspicion of a nodule, then you can go ahead and do an ultrasound scan of the patient. Do we need to do fine needle biopsies in all thyroid glands? No, we don't do unless you need to evaluate for a thyroid 4 above nodules. I think you know about thyroid scoring in ultrasonography. If you're only suspicious, we do it. We not for different type, with the thyroid 2, 3, we observe. We don't do FNAC. Definitely not for a diffuse goiter. I have seen so many fine needle aspirations being done unnecessarily on a diffuse goiter. So don't go and do that. You don't have other methods of confirming a diagnosis of Hashimoto's than pricking a needle and saying it has lymphocytes, right? And as I said, if you need to evaluate for the nodule, please do. When they suggested the highly suspicious nodules, we should not let them go. We should do a fine needle aspiration. So diagnostic criteria as for Hashimoto's thyroiditis is based on clinical features and biochemical investigations both. And best serological marker is the TPO antibody being positive. 95% will have it positive. For a diagnosis, for you to write a Hashimoto's thyroiditis, they should have an antibody positive in your diagnosis. So this can be associated with other autoimmune diseases. So we see very commonly now other autoimmune diseases, when especially you should think about when these patients are having concomitant anemia, not responding to iron treatment, but this is pernicious anemia going on. And I've seen patients after treatment for hyperthyroidism getting them euthyroid. They say, Doctor, I'm feeling so tired. I'm lifeless. I get dizzy spells. I don't feel right. So this is where you should think of Addison's. Coexistence of Addison's and hypothyroid are becoming commoner and commoner and commoner. We diagnose so many patients in our clinic visits with Addison. So we always think of these patients because they don't present to you with pigmentation and so on. They don't crash on you on clinics. They don't have a crisis in clinics, but they have subtle symptoms that develop gradually. So always think of a fully euthyroid patient. You biochemically have make them euthyroid with a normal TSH, good dose of thyroxine, but still not responding. Please think of Addison's and do a 9-name cortisol, because that is where we see the polyglandular syndromes of Schmidt's disease. And type 1 diabetic patients are high risk. We annually do TSH in these patients. So other autoimmune diseases like rheumatoid arthritis, myasthenia, celiac, autoimmune hepatitis are other coexisters. So basically other autoimmune diseases can happen in any patients with Hashimoto's thyroiditis. So how do we manage this common clinical disease? Is a challenge, I think, to you and me throughout, whether we are in endocrinology team, with the physicians, family physicians, GPs, all around, even for surgeons, is a kind of a tricky thing. So in general choice, whether to treat or to replace with thyroxine. It's very important you decide to observe or to treat. Patients with overt hyperthyroidism, that is TSH above 10, there's no question, we treat them, replace them, especially when they are less than 70 years of age. Those with subclinical hypothyroidism, we have a TSH between 4 and 10, T4 normal. It is influenced by the level of TSH and the clinical factors, right? I will explain to you about this. So the algorithm for deciding on treatment is the age. If you have a patient less than 70 or younger, if you can see here, I will point out. If your patient's TSH is less than 10, that is, you are having subclinical hypothyroidism diagnosis, but without any symptoms, then you observe and repeat your thyroid function tests in 6 months. You wait. If the TSH is 10 and no symptoms, you say, I'm quite fine. I've seen many patients like that. I've said, I'm quite fine. TSH 7, 8. I don't feel anything. So don't start treatment for asymptomatic patients if they are having no symptoms. But even if less than 10, they have hypothyroid features, says I'm lethargic, I'm tired, I'm losing my hair. If they have symptoms, please give a trial for 3 months and monitor their symptoms and the TSH. That's a kind of a trial. But if you have a patient less than 70, young patients, more than 10 of TSH, you start their T4 treatment with thyroxine because most of them will be symptomatic. If your patient is over 70 years of age, This is very important. Over 70 years, if it is less than 10, you observe. You don't start treatment if their age is more than 70 for less than 10. And you repeat the TSH. Look at the sequence, how it is going to increase or decrease. You wait, you observe. Even if your TSH is more than 10 in patients above 10, about 70 years, with no symptoms and no vascular risk, you wait, you observe these patients. And only if their TSH is more than 10 with clear symptoms, with high vascular risk, you consider treatment of thyroxine. The reason is with your age, increase in age, your TSH is going to get higher. So a TSH of 7 could be quite normal for age of 80-year-old patient. You're not going to jump and start and say, you are having hypothyroidism, let's start you on thyroxine. Please don't do that, right? You wait. If a patient is above 70, cautions before, if it is less than 10, you just observe them. I've seen many patients being put into risk by giving thyroxine for just marginal TSH values. So how do we replace this? The goal of thyroxine therapy is to achieve clinical and biochemical response together, which is quite impossible sometimes. So levothyroxine remains a treatment of choice. We don't give T3, it's not available commercially, but some countries do. We only have T4 or levothyroxine treatment. You can see the treatment difference after treatment, patients with hypothyroidism. So when you prescribe your thyroxine, it's important, few things. You decide on the dose. You are the decision maker there. How much of thyroxine should I give these patients? Young patients with overt hypothyroidism that is more than 10, you start them on full replacement dose. Don't start on lower doses and wait. You start them on full dose. If your patient is older, above 60 years, you shall start low, around 50 mics per day. And if your patient is having a risk or even coronary heart disease, you start at even a lower dose of 12.5 to 25, and you gradually increase. An older patient should be instructed to report any chest pains when you start on thyroxine therapy. For subclinical hypothyroidism, the dose is usually around 25 to 75. That's basically the weight of the patient. If your patient is weighing around 50, you start on 50. Equivalent to weight would be one of the best guesses, but if you're starting, let's say, from very marginal TSH, you can start with 25. Overt hypothyroidism, you start full replacement provided there is no unstable ischemic heart disease, especially young patients, you can start. So what is this full replacement dose? It is 1.6 micrograms per kg per day of daily dose. We multiply it by 1.6. But we've seen that when you have, let's say, radioactive iodine treatment, or if you're having total thyroidectomy, you might need 2 times, that's 2 micrograms per kg of weight. So you multiply the weight of the patient by 2 if you completely remove the gland, they would need higher doses than for patients with overt hypothyroidism. You can prescribe and say you go and take this medication. It's never going to work. How much of instructions we give, we see commonly in day-to-day practice, the way we have prescribed, probably part of our fault as well. We have not given the correct instructions to our patients how to take this thyroxine. It is so important you give these instructions first when you see them on the first clinic visit. Storage, it is very important. They should store in a cool, dry place, protected from light and moisture. They should not be keeping this just on table, near the window where there's a lot of heat. Some store it near the stove. It's easy for them to take thyroxine when they cook in the morning, or even above the fridge, on top of the fridge, where it's really hot. So when there is stored not in a kind of hot area, even if you just carry in your bags, in sun, in outside, it's not going to work. So it has to be stored in a cool, dry place. Some countries even advocate to be kept in the fridge. If you're living in a hot country, they can put it not in the refrigerator, but you can keep it in a cool fridge as well if you have that facility. And this should be taken empty stomach, first thing in the morning, with water, little bit of water, not full-blown glass of water, sip of water, at least 30 minutes, preferably 60 minutes before tea, coffee, or any kind of food, because the time it needs to absorb is minimum of 30 minutes in an empty stomach. So why do we say empty stomach? So first thing in the morning, because we have to instruct them. So some, especially in pregnancy, they probably get up early in the morning to go to the washroom, all that. So the timing is from the last meal you've had. If you are waiting for 4 hours to take your thyroxine, you just emptied your stomach. Let's say you had your dinner at 10 o'clock in the night. By 2 p.m., you have an empty stomach. So you can, after 2 p.m., you can take your thyroxine anytime. So it's not just first thing in the morning, it can be any time from your last meal, you can take a thyroxine. This is for the ease of us to tell the patient, because they're fasting, most of the patients. But you will see patients who are doing night duty, who are not working on the Sri Lankan clock, they are working for other companies. The timing is so different for them. So this is the instruction: from your last meal to 4 hours, you don't take anything, then you have an empty stomach, you can take your thyroxine, right? So other medications that we take should be taken separately are the calcium and the iron. It's very important. And if you miss a pill a day, there are two ways you can rectify that. You can take on the same day. If you wait for 4 hours from your last meal, let's say you just had your breakfast, you forgot to take your thyroxine, from breakfast time at 8, if you stay fasting for the next 4 hours without any food, you can drink water, you can take your tablet at 12 noon. Or you can double the dose next day, because as you know, thyroxine has a half-life of 7 days. So you can double the dose next day. So within the 7 days, you can catch up the dose in thyroxine. So these are the two ways you can rectify a missed dose. That is very important to tell this instruction to your patients. And different brands of thyroxine are not bioequivalent. I should rephrase this. So say you're going to switch from one brand to the other. Please do your TSH again after 6 weeks to 8 weeks of switching, because it's not bioequivalent. Though all these brands are different, or the dose is same. When you change a brand, please do. I've seen many patients, we can even reduce some of the, or like very good brands or original brands, we can even reduce their dose and without making them hyperthyroidism. Any brand change, you should require to have a TFT. So most patients ask, what are the side effects of having thyroxine? Because when you have thyroxine for lifelong, we say this is for lifelong treatment. One of the questions they have is, what are side effects of getting this treatment lifelong? There are no side effects if you give them in the correct dose and you replace them the correct dose with making them euthyroid. Over replacement and under replacement is the side effect. So if you over replace these patients, they could be having atrial fibrillation, they are more prone for accelerated bone loss. I've seen many patients sometimes subtotal thyroidectomy, they have the gland left, but somebody prescribed them thyroxine and they're being it for years when they have a normal functioning gland because they had a subtotal. And then sometimes we start them on thyroxine. They've never come to a clinic. I even met a patient today, started on thyroxine, never done a TSH for the last 4 years. Just imagine having patients like that. So over replacement and under replacement is a side effect. Not having this in appropriate doses for life, there is no problem if you monitor them appropriately. So how do we follow up these patients? Dose adjustments are guided only by TSH. Please do not do T4, T3 for follow-up. This is only for diagnosis if you really need it, and that's it. There's no T4. It's because we see they come up with a TFT. So all three, TSH, T4, is very costly. So just do a TSH. So when you start your treatment, the minimum time you can do it is about 4 weeks. Ideal would be for 6 weeks to 8 weeks, right? So you should get the TSH, the lower half of the reference range. Let's say you had a patient of TSH 6 and making them into 4, this is not the correct replacement. You make them into lower normal between 0.4 to 2.5. Ideal would be to have between 1 and 2. That's the ideal TSH your patient should be having. So they should be after replacement dose. You decide, you say, okay, this is the correct dose, the brand is correct, and everything else is set. Then you repeat your TSH after 6 months, and if everything goes well in 6 months, you can do it yearly afterwards. We don't do it every 3 months, every 6 months after that. If your conditions are stable, if you're given the correct instructions, and you're pretty sure the patient is going to be compliant on treatment. But when you replace this, patients with severe hypothyroidism, they might not come back to you and say in 6 weeks, I'm quite normal. It'll take them sometimes months to get there. The biochemical response will be there, but symptomatically, they might not get the response as well. Even sometimes, some patients, biochemically, it takes time. So be patient with these patients, and it takes time. So wait, and especially if severe, like more than 100 TSH, will obviously take time for the response. So as I said, yearly surveillance is very important. And is there a risk of cancer in Hashimoto's thyroiditis? There is a relative risk of thyroid lymphoma in patients with Hashimoto's thyroiditis, but absolute risk is very, very low. So when do you suspect this? When you have a goiter which is enlarging rapidly, patients come and tell you, this was not there last 6 months, I feel it's growing. Then you be cautious and do your examination, do your ultrasound scan, and look for, this is a very, very rare complication of this disease, but they have a risk as well, not just nodules. What are the problems we encounter with thyroxine therapy? So you treat them, they come back to you, still their TSH either the same or just a bit low, not in the normal range, despite high doses. So when I see, the first thing I ask is, did you miss any tablets? Just even one tablet. So when you say that, just tell us, and they would probably say, but they might not as well. But you should tell them the importance of telling the poor adherers, because we're just going to increase the dose. Just tell us whether you've missed any single dose, and they will come up and tell you, yes, I missed, I forgot to take it, or my drugs were over, I couldn't go and get it back. The second one is impaired absorption of thyroxine. So there are drugs which can affect the dosage of thyroxine. Drugs which prevent absorption of thyroxine are the calciums, iron, aluminium hydroxide, cholestyramine. And there are drugs which can increase clearance of thyroxine as well, like phenytoin, carbamazepine, phenobarbital, and rifampicin. So these drugs might interfere if you have a patient on coexist, especially in pregnancy, on calcium, iron. If they are not going to normal TSH, we ask them to at least wait 4 hours from having thyroxine to calcium, and that can mostly mitigate the problem. So that is about overt hypothyroidism. So my second case is on a female investigate for subfertility. This is a very common referral to us with subfertility. So out of the band of investigations, TSH comes very high up in subfertility. And this patient had a family history of thyroid disease, but there was no goiter in this patient. And you can see the TSH is just marginally high, less than 10, but just above 4. T4 is in the normal range, but she has a positive antithyroid peroxidase antibody. TPO is positive. So what would you do in a patient with subclinical hypothyroidism with antibody positivity? How do we manage these patients? So one of the commonest referrals, and I think in your practice also, to decide, am I going to observe? Am I going to treat? And they have minimal or very sometimes no symptoms and normal levels of T4, T3. So if you have no symptoms, as I said, what you can do is do annual surveillance with having the thyroid function test, because then we can detect the progression and development of symptoms over time. The risk of development to overt hypothyroidism is less than 5% per year. That's why we do it annually. But if you're really cautious with having any young patients, like this subfertility, if you want to decide on something, then you can do it in 6 months as well. What about the females of this category, subfertility? How to treat this patient? So there are not very clear evidence for this treatment to determine how to give the T4 treatment in subclinically hypothyroid, but antibody negative patients, right, who are attempting natural conception. Say you have a patient of TSH 4.5, antibodies are negative. Am I going to treat this patient if there is no symptoms? But what we do is we can prevent the progression into overt hyperthyroidism once the pregnancy is achieved. So we can start them after pregnancy as well. So then we start with low thyroxine levels in this patient, 25 to 50 mics a day. And some of the studies have shown that but this study was done in 94 infertile women with hypothyroidism. They were treated with thyroxine, very low doses, and some are high depending on their weight. And they conceived. 72 of them conceived spontaneously within a year. So patients with hypothyroidism, just marginal TSH, subclinical treating is sometimes very tricky. But if you have a subfertile patient, please do their antibodies, and antibodies will guide you. Because when you have a positive antibody, that will have a twofold increase in risk of pregnancy loss, right? So this is subtle deficiency of thyroid hormones. They're involved in fetal development, placental physiology. But if you have completely normal T4, T3, TSH, and a positive antibody, still there's no recommendation to treat. But some of the studies say if you have a patient with recurrent miscarriages, normal T4, T3, everything is normal, just the antibody being positive, there's a place of trial of T4 in this treatment in these patients with recurrent miscarriages. And that's very important. So this is in subfertile patients. If you have a subclinically hypothyroid patients, please do their antibodies. If they are positive, we advise you to treat these patients. If they are negative, with this no history of miscarriage, you can still wait and you can observe them. What about in pregnancy? It's very tricky in pregnancy if you have patients with thyroid disorders because it's high risk of serious clinical consequences if untreated. Subclinical hypothyroidism can reduce fertility. We need to optimize their TSH levels. And untreated overt hypothyroidism above 10 TSH is associated with risk of miscarriage, preterm delivery, gestational hypertension, preeclampsia, low birth weight, even fetal death, and impaired child intellectual development. That's very important. We treat overt hypothyroidism. Right. So when a known patient with hypothyroidism becomes pregnant, you increase their thyroxine dose by 30%, even without doing a TSH. You can increase it by 30% till you get a value. Let's say your patient is on 75 micrograms per day, you increase it to 100. By about 30%, you increase the dose because the fetal requirements are higher during pregnancy. It's very important to know that till you meet your doctor. That's instructions given prior to, say you're planning a pregnancy, you tell the patient you're now on correct dose, but when you know that you're pregnant, you increase by 30%. You teach them how to do that, the dose, because that's important for the fetal well-being. So moving on from hypothyroidism to hyperthyroidism, probably you're not sleepy by now and fully awake, because this is area where we make a lot of mistakes. This is a case, 19-year-old male presenting with loss of weight, palpitations, increased sweating, diarrhea for 2 months, common symptoms of hyperthyroidism, sweaty palms, tachycardic. He has a goiter. You can see his TSH quite low, T4 being very high. Antibodies were done for TSH receptor antibody. Please do not do TPO antibodies for hyperthyroidism. What we do is a TSH receptor antibody. This costs about 15,000, and you can think twice whether you really want to do it or not. We do it in cases where we really think it's necessary, but probably not for all patients in our setups. So when you do ultrasound scan, you would see a diffuse enlargement, increased vascularity. So the key features, when you are thinking of thyrotoxicosis, look at your ultrasound scan reports to say whether it's diffuse, are there nodules, is a vascularity. It gives a good sense to us in patients. You have sometimes subtle features just above margins of levels. This could be due to viral infection sometimes even Gestational thyrotoxicosis, the gland vascularity gives us lots of information, and please look at it. So diagnosis for this patient is having thyrotoxicosis. How do you manage this patient? So this is a good statement. All hyperthyroid patients, right, have thyrotoxicosis, but not all thyrotoxic patients have hyperthyroidism. These terms are used synonymously for, let's say, we just say hyperthyroid, thyrotoxic. It's not the same. Hyperthyroidism is where you produce your thyroxine levels and the problem is just in the thyroid gland. You're producing a thyroid hormone, it could be a goiter, a Graves' disease, that is hyperthyroidism, and that leads to thyrotoxicosis. So all causes of thyrotoxicosis is not due to Graves and multinoidal goiter. There's so many other causes, and so you can't use this synonymously. This patient is having thyrotoxicosis. We need to find the cause of thyrotoxicosis. One of the causes is hyperthyroidism. So this is the hyperthyroidism is hypermetabolism resulting from excess quantities of thyroid hormones. It ranges from subclinical hyperthyroidism to life-threatening thyroid storm. And the major causes are the Graves' disease, the commonest toxic multinoidal goiter, sometimes solitary toxic adenomas, and they are more commonly seen in women. And symptoms are pretty much same as sometimes for anxiety. They could be nervous, they could be having a tremor, irritable, difficulty sleeping, and if they have features of ophthalmal orbitopathy, they can have periorbital swelling, they can have proptosis, and all that can be seen as well. Regular menses, and they have diarrhea, sweaty palms, they are tremulous. Miscarriages are sometimes common, and they have palpitations, tachycardia, fertility, weight loss, sweating, and sometimes muscle paralysis can be seen in severe forms, and most of them would have a thyroid history, family history. So out of these cases for hyperthyroidism, Graves is the commonest we can see, and then the toxic multinodular goiter and the autonomously functioning thyroid nodules are there, and the other causes. Risk factors are the females, advancing age, family history, pregnancy, and smoking is one of the risk factors for thyroid hyperthyroidism. So these are the causes for thyrotoxicosis, not the hyperthyroidism. So if you have a patient with a normal or elevated radioactive iodine uptake, Graves, toxic nodular goiters, trophoblastic disease, CSH secreting pituitary adenomas, or resistant to thyroid hormones are common. And if you have a radioactive iodine uptake, which is near absent, patient is fully toxic, but the gland doesn't show any activity. This is subacute thyroiditis, acute thyroiditis, silent thyroiditis, other causes of thyroid destruction like the drugs, amiodarone, radiation, infarction of the adenoma, and there could be thyrotoxicosis, factitia, excess ingestion of thyroid hormone, iatrogenic thyrotoxicosis, which we have made them toxic, and excessive metastasis from follicular thyroid cancers or struma ovari. So these patients, gland is not actively showing in radioactive iodine. They have an absent iodine uptake. When they're normal, so these patients are still having thyrotoxicosis, but not hyperthyroidism. This is the difference I was talking about. So these patients warrant a complete detailed history and thorough physical examination. We need to do the TSH and T4, and we do T3 only when the T4 levels are normal. We don't need all three. T4 is quite sufficient for this, and we can measure the TSH receptor antibody, which will give us a diagnosis of Graves' disease, and we need to know the their reference values as well. So this is kind of the evaluation of thyrotoxicosis. So say you measure the TSH and T4. If your TSH is low with T4 being high, that is primary thyrotoxicosis. If your TSH is low, T4 is normal, and then you measure the T3. If it is high, this is the rare form of T3 toxicosis where you have a T4 normal and TSH being high. But if your T4, T3 both normal with a normal low TSH, disease subclinical hyperthyroidism, and there are very few instances we decide on treatment for these patients. We just observe them 95% of the time. And if you have a TSHB normal, but your levels of T4 are quite high. So what are the reasons for that? That could be, this is a kind of MCQs for guys, TSH secreting pituitary adenoma, and the rare cause of thyroid hormone resistant syndrome. So these patients were evaluated for some other things or a goiter, quite normal TSH, but all their T4, T3 levels are quite high, and most are asymptomatic. It's from childhood they're having. So then think of thyroid hormone resistance in these patients. Okay, so let's go back here. So we have features of Graves' disease. If you have, now you diagnose them with it. But if you have a multinodular goiter or toxic adenoma, then you have to think, well, this is a toxic nodular hyperthyroidism, and then we manage as accordingly. And if you doesn't have a multinodular goiter or toxic adenoma, and if you have low radioactive iodine uptake, this could be due to destructive thyroiditis, iodine excess, or excess thyroid hormone, where you are showing low TSH, high T4, but the uptake was quite reduced. If their uptake is completely normal, then we have to rule out the other causes like medications in these patients. So make sure you diagnose your thyrotoxicosis patients are a bit tricky in management, and don't be in a hurry to diagnose subclinical hyperthyroidism and start treatment. If you diagnose these patients who have thyrotoxicosis, please start treatment, whether it's a toxic goiter or a Graves' disease. The treatment is quite same as initially, but the end treatment will differ depending on the cause. But you start on anti-thyroid treatment for these patients if they are biochemically and clinically toxic. So how do we manage these patients with the hyperthyroidism? It's quite interesting. So there's medical management, radioactive iodine management, and surgical management. So whom would you offer these three treatments? All the patients, this is very important, all the patients first need medical management. You have to make them euthyroid. Even if you want to send them to urgent radioactive iodine treatment, urgent surgery, you have to make them medically euthyroid. So how do we do that? One, we control symptoms, and we then control the hyperthyroidism. So how do we control symptoms of tachycardia, tremor? Because drugs are going to take some time. So we can start always the beta blockers, calcium channel blockers if they're asthmatic, and we discontinue. Do not continue this treatment once the patient is euthyroid. Next visit, you discontinue. This is just symptomatic management. I've seen propranolol going for years in this patient and being bradycardic. You don't need that. But just for symptomatic, minimum of 6 months, maximum of 6 weeks to 2 months, you would need the symptomatic treatment of beta blockers. So then we try to control the hyperthyroidism. The options we have the carbimazole, methimazole, and the propyl thiouracil. And the commonest we use is the carbimazole, and it can be usually given in a high dose, and we start reducing the doses. And some use thyroxine for block replacement. That is not commonly used and not advised as well. So the commonest we use by using high doses first, and then with the clinic visits we try to reduce the doses. And by treatment of the thyrotoxicosis with the thionamides, the carbimazole, remission of Graves' disease about 50%, right, after 12 to 18 months. The problem is the remission. 50%, around 50% comes back, remission after the giving the medication. It's very important. So whom do we offer the radioactive iodine? So it's very difficult task. One of the difficult tasks is to convince them for radioactive iodine treatment, and because they don't know it, they fear the side effects, they fear risk of cancer. And the indications would be, if you have a patient, it's very clear information here. If you have a patient with a toxic multinodular goiter or a toxic solitary nodule goiter, you are not going to keep doing medical treatment because you have a structural lesion. So you have only two options. You bring them back to euthyroidism with the medical treatment. Either you go for radioactive iodine or you go for surgery. So these two options should be offered to the patient. Not continuing the medical treatment for 18 months is not the choice for nodular goiters. It is just for Graves' disease of a diffuse goiter, antibody positive. You didn't tell the patient from the start. This is a treatment course for 18 months. You have to complete 18 months. You're going to have a remission, which is not going to work. Drugs might not work as it worked first time as well. So you don't tell this halfway through. You tell them the first time you meet them, this is your treatment plan, because they're going to default. After 8 weeks of treatment, they are going to feel completely fine, and they would think, why should I continue 9 tablets of carbimazole? And pretty horrific side effects if you search on Google, and they're not going to continue. So you tell them the need to continue these medications for 18 months. So while you're taking these patients through this journey, if you have a patient with toxic nodular, give these two options: either radioactive iodine treatment, which might or might not work for nodular goiters, depending on their nodularity, the size of the nodules and all that, but we can always offer. The second set we offer radioactive iodine is for uncontrolled resistance, recurrence patients with Graves' disease. That is the second group set of patients. We give this treatment of radioactive treatment. So cautions in some pregnancy, they can't get pregnant for about 6 months. Some say for even 4 months. And caution when you have a thyroid eye disease might get a bit worse, but you can cover it with prednisolone. And patients who are breastfeeding, do not offer them radioactive iodine, and 90% of them will become euthyroid after first dose. So very rarely they would need the second or the third dose. If they've gone to the first dose, they're not reluctant for second dose because they know what it is by then, which is very simple treatment. And when do you offer surgery? If there are contraindications to medical treatment, if there are severe allergies, severe contraindications, like let's say they get agranulocytosis on carbimazole, we then have to take them through surgery. And in severe cases, and relapse, Graves' disease, relapse eye diseases, they're continuing even after radioactive iodine, you offer them surgery. So far, I've not offered surgery for any of my Graves patients, which are fully controlled with the radioactive iodine, either for the first, second, or I had one patient on third dose of radioactive iodine who's doing wonderfully at the moment after 4 years of treatment. And if you have suspicious nodules, there's no point giving treatment. You make them euthyroid and you make them go for surgery. And if the patient prefers, say, no, I don't want radioactive iodine, please, I need the surgery, then that's the patient preference. You can go ahead as well. So as you all know, there are complications of thyroidectomy as well, but no, it's kind of a cure for thyrotoxicosis at the end. But there's possible hypothyroidism, hypocalcemia, all that set in, but it's a cure. But we offer them this for toxic nodules, not for Graves' disease initially, because they can be cured with radioactive iodine when they relapse. So how do we decide on the starting dose? Say you have a patient in front of you, you have to now decide how much of carbimazole I'm going to start for this patient. If your free T4 level elevation is about 1 to 1.5 times the upper limit, you can start with 10 to 15 milligrams of carbimazole. This can be given as a single dose or divided doses. If your levels are 1.5 to 2 times the upper limit of normal, you can start with 20 to 30 milligrams per day. If you're having 2 to 3 times upper limits normal, then you can start with 50 to 70 of, there's probably 60 where we use mostly, but we can go up to 70 as well of carbimazole. If you have very high levels, then you start back reducing their doses depending. So how do we follow up? I don't think I think if your take home message out of this whole presentation is not to follow your patients with a TSH. It's going to take years to recover a TSH. The problem is not in the TSH, it is in the T4 levels, active hormone. So you follow up these patients only with free T4 or T3, depending whether they're having T4 toxicosis or T3 toxicosis. So if you have done both levels, then we use the most higher level. They had the upper limit for follow-up. sometimes we monitor T3 in these patients. Then after 2 to 6 weeks with thyroid function test, usually we do it around 6 weeks, and then we titrate it, lower the dose. If your patients are under control, let's say first visit you take this patient, it's now coming into within the normal range, then you start reducing the dose. In the normal range means we can start reducing depending on which level the patient is. Is the lower side of the normal or upper side of the normal? So if it is the upper side, we wait for another 6 weeks or 8 weeks to reduce the dose. If it is the lower side, we're making the patient hypothyroid, then you start reducing by 5 to 10 milligrams per session. You slowly start reducing. So how much do you reduce? You should come back to about 5 per day as one tablet, 5 milligrams per day, and you keep the patient on that till you complete the 18 months. You have to won't be on high doses for 18 months. Don't make them hypothyroid. You monitor their free T4 levels and start reducing the doses. When they are in the normal range, you start reducing. Don't continue on that, because the purpose is to get them into the lowest possible dose, which is 5 or even 2.5 sometimes, but complete your course of 12 to 18 months. So duration is approximately 12 to 18 months, and you discontinue when your TSH and TREB levels are in the normal range. So if you have kind of confusion whether to stop or not, and sometimes in patients with large goiters, we can do a TREB level. If your antibodies, the THS receptor antibody is negative now, you can stop, because all this purpose is to get these antibodies negative. By first 6 weeks to 8 weeks, you have made them euthyroid. You have cured them of the disease. So I'll tell them, okay, now you're off the risk. The reason we are continuing this treatment is to reduce the chance of a recurrence. 18 months, right? So if you're not sure, you do the antibodies again. If the antibodies are negative, TSH within the normal range, then you can stop treatment. After stopping treatment, what we do is we monitor them for the first 1 year. Don't let them go for a year. The highest relapse we've seen is within the first 6 months of stopping treatment. So we get them either 6 weeks or 2 months, then at 3 months, 6 months, and at 1 year. If they are completely remission after 1 year, you can let them go from your clinic and say you can review your SOS as needed. If you get symptoms, you come back. I had patients who relapsed after 15 years of stopping, so it can come back anytime, but the chances are very, very less if you are not relapsing at 1 year after treatment. That's very important for you to know. And I have put a few questions here for things we could not discuss as cases. So I think this is a very common scenarios you get in a clinical practice. You can see this is a 12-year-old young chap coming to you, investigated for lethargy by the general practitioner, because children are brought by parents say they don't study well, I don't think they're doing quite well, they're not eating well, they're lethargic, and we tend to do a TSH, which is quite good as well. But the quiet examination was normal. So you can see a TSH of 7.2 and was referred to me, which is a real patient, referred to me in clinic. And what do you think is the most appropriate next step in management? Whether to treat with levothyroxine, do the FNSE, do antibodies, do ultrasound scan, whether to observe or do either the antibodies and do ultrasound scan. So what do you think? A child, 12 years, coming to you with subclinical hypothyroidism. Any guesses? Just to see whether you are awake.
Treat with thyroxine.
Any other answers?
Better do a scan. Do the scans and to see whether the gland is dysplastic.
Yeah, okay. Good answer. Any other answers?
No.
So actually in this juvenile thyroiditis, right, this is very, you have to be very cautious in labeling them as subclinical hypothyroidism. Over is fine. If it's more than 10, there's no question. We start treatment. We do the necessary investigation, antibodies. Yes, you do that and you start treatment. Subclinical is the problem where there are symptoms and there have symptoms as well. Then we tend to say, okay, shall we? Sorry. Yes, sorry, So in these patients, you can see somebody asked for an antibody. So I did the antibody. It's 1.5. The normal is less than 30 is normal here. So the antibodies were negative. I did ultrasound scan. All the neck examiner was quite normal. There's nothing in the scan, completely normal. So what you should be looking in a scan, look at the size of the gland and look at the echogenicity and it is heterogeneous or not. Uniform echogenicity or heterogeneous. If it is uniform, it's quite normal. If it's heterogeneous but increased vascularity, there is a tendency for hypothyroidism, or even in hypothyroidism, you would see that as well. This gland is completely normal. The size was normal. There's clear echogenicity, antibodies negative, right? Then we come to a scenario where a child coming with subclinical hypothyroidism, other investigations are normal. What should we do for this patient? In this case, what we should do is observe, not to start treatment for this patient, especially in the age of pubertal changes. They have changes. Even sometimes a small goiter you can see with the pubertal changes. So don't be in a hurry to start them, labeling them as hypothyroid and start treating and giving a trial. Please do not do that. If you have antibodies negative, a normal scan. You repeat the TFTs in 6 months and see the progression. If they are going, I've seen about more than 95% come back to normal range after 6 months. They do not require any treatment and it's completely normal. If your antibodies are positive, if you have a scan showing bit of heterogeneity, obviously the TSH higher is showing that it's going into overt hyperthyroidism, then you can do the treatment. You can start on the thyroxine according to the body weight, 25 mics most likely in children according to their weight, and then you monitor their TSH. Only if the antibodies are positive, only if the gland is showing heterogeneous gland with increased vascularity and symptoms, then you decide. Even for symptoms, do not start treatment in young children when you have negative antibodies and a normal scan. So that's my message for you in managing children with subclinical hypothyroidism. This is another common referral. A 25-year-old was referred by gynecologist for subfertility, asymptomatic, completely normal examination, no goiter, and you can see the TSH. It is not overt, 9.0, and upper limit of subclinical hypothyroidism. It's above 4, less than 10, referred saying this patient is subfertile. Give your opinion for the management. So what are the best options for this patient? No treatment, do antibodies, ultrasound scan, and treat with thyroxine. What do you think is the best option? Any guesses?
Antibodies.
Yes. Any other answers? Good.
Treat with levothyroxine.
Treat with levothyroxine, okay. It would suggest no treatment as well, subclinical upper limit. So I talked about subclinical hypothyroidism there. So it's important that we do antibodies in these patients. That is one thing, is that higher the antibody levels, we know that this is the cause and this is chance of crossing that antibody to the child. If there's no way you can do it, the best option here would be to start treatment. Even if this patient is not having overt hypothyroidism, this patient of having risk of miscarriage is higher and the fetal loss is higher. So we start with levothyroxine treatment for the body weight. So this is overt, almost overt. So we can go for 1.6 into body weight in this patient and start treatment. The cutoff or the level we need to get these patients are below 2.5. Don't get them to upper 4, upper 3 levels. Get them below 2.5 TSH levels before they conceive. Even for patients who are on thyroxine prior to conceiving, the target is of less than 2.5. And you make sure your patients are in this target prior to conceiving and give them the correct advice that you need to keep this to start planning your pregnancy. So I would start treatment for these patients, even without antibody, as some said, I would start treatment for this patient. Let's say this patient came with just marginal antibodies, 4.5. There was no history of miscarriage, just subfertility. Even if the antibody is negative, I would start treatment for this patient because the risk of having a progression in fetal loss is higher. Although we don't have a lot of evidence, we are not going to give a reason for this to be the subfertility cause because we do not know. We don't have enough evidence in this. And so trying giving us very small dose and getting them into less than 2.5, even in antibody negative patients, is worth for us because there's no clear evidence for us. We can choose according to patient. So I would start in my practice, even with subclinical hypothyroidism, subfertility, recurrent miscarriages, I would start. I have started treatment for TPO positive patients with normal TSH, T4, T3 with recurrent miscarriages to get them into a pregnancy with very low doses of T4 and monitoring them with TS. Although it was normal, the antibodies are very high. In this, there's no clear-cut evidence, so there are individual cases we can decide. This is the gynecological and the pediatric cases are the bit tricky ones to manage in your practice. So I've come to the end of my presentation and I would welcome any questions, please.
Madam, in the chat box, we have a question surge actually. So the first question would be, do we have to check the free T3 levels too?
Probably for the TSH lower patients, hypothyroid, no. We only check T4. T3's levels are measured only in toxic patients when the T4 levels are normal. Because T3 levels are quite dodgy results. It can vary according to even the time you collect the sample. Throughout the day, a lot of variations. And even the analytical problems are there in T3. So you must have sometimes seen patients, TSH is completely normal, T4 is normal, and T3 is just high. And refer to the easiest patient having toxicosis. No, you can never have a thyrotoxicosis unless it's a very rare cause of high thyroid hormone resistance. Even that you will have both T4, T3, both high. Just isolated T3 is not going to be high in patients. It's most likely an analytical error. You repeat the test and it's going to be normal. So just don't based on one T3 or one just isolated T4 levels, don't get into judgments. There are so many errors in thyroid function tests. Most of the major laboratories, the hospital laboratories does it well, but I don't think even the smaller ones does it well at all. So you have to be very cautious in interpreting your thyroid function tests. Always correlate with the symptoms.
Okay, the other question is why taking on empty stomach? It's about thyroxine in the morning.
It's absorption. When it's absorbed with food, it doesn't absorb well. So let's say you just had your thyroxine, I just had a cup of tea, and that's food. Tea is food, not the plain tea, I suppose, is food. So it does not absorb well with food when you have food in your stomach. That's why we need the empty stomach for absorption purpose. Absorption is very tricky. Even patients with absorption disorders, they would also have problems in absorbing patients.
What is the role of T4?
T4 role, there's no role of T4 in hypothyroidism at all. That's why we do not get these patients with T4 level because we are monitoring hypothyroid patients only with the TSH between 1 and 2. That's what we want. That's the opposite of thyrotoxicosis. We only do T4. We do not do TSH. It's two different sets. So remember that you never, ever monitor your toxic patients with TSH, only with T4 levels. I've seen patients remission for years with lower TSH, but completely normal T4. After even stopping, sometimes we had to stop treatment, antibodies negative, still the TSH doesn't come into normal range. So we still can stop it. And don't be misguided by the TSH in toxic patients. It has no role in your management.
And another question, madam, do we have to exclude Addison's before starting thyroxine in each and every case of primary hypothyroidism?
No, not at all, because those don't things correlate. We can't start thyroxine in any patient, even if you're suspecting Addison's disease, you're not going to go into a crisis. The problem is we do not. If a patient has clinical symptoms, we've diagnosed them clinically together, but it's very rare to have both together at the same time. One thing would be we have missed one and we have treated hypothyroidism and later patient does not respond to treatment, then we think is this patient having hypothyroidism, and we are seeing it quite often now. So the clue here is if you have symptoms, examination, clinical features, please do them together, cortisol, TSH. You can start thyroxine before you treat Addison as you don't go into a crisis. But most what happens is you start treatment for the obvious one. Addison is not obvious at all, and unless you've gone into a crisis or having severe low cortisol levels, you do a 9M cortisol. And here I would just drop in a message to you about 9M cortisol. We do it at 9M, no need of fasting. And when you do the 9M cortisol, the ideal would be to have it more than 550 nanomoles per liter. If you're in micromoles, it's different. And the cutoffs would say 550, but anything above 400 is quite okay. If they are to have symptoms of Addison's or pigmentation, hypotension, this should be mostly lower than 200. So anything around 300, because we do not have a reference range of 9M cortisol for our population. We don't know what's the norm for us. We say it's 550 for all, but no. You've seen patients hanging around 350, 400, quite fine. They undergo short synactin, quite fine, good response. And so be cautious in interpreting and starting cortisol as hydrocortisone as well. Make sure you get a short synactin test before you start for Addison's if the 9M cortisol is above 100. But below 100, you don't have to short synactin. Just go ahead, we start hydrocortisone. If the 9M cortisol is less than 100 nanomoles per liter, it's fully diagnostic, the symptoms. And it's a quite challenging to get a short synactin, even for us. Very costly test at the moment in the private sector. The synactin is not available. It costs about 75,000 per test. And in the government sector, we are waiting for synactin for months sometimes. It's quite sad not to have synactin, to do synactin tests frequently for us. Yeah.
If TSH level is normal continuously, can we stop levothyroxine?
No, that's very important. Let's say the primary diagnosis is primary hyperthyroidism over more than 10. You're never going to get your thyroid gland back again for normal functioning without. So that is important to know the initial TSH is above 10. That's continuous, lifelong. Now the questions come for subclinical hypothyroidism. You start treatment and they feel better and they will ask you the question, how long should I continue? So the answer here would be, if you're having a patient who's planning pregnancy, young patient, the advice is to continue thyroxine, at least you complete your family. If you want to have one child or two children, till you complete, you continue on thyroxine, and then later you can stop and see your response. That is for subclinical hypothyroidism. And if you're starting it for older patients, let's say with ischemic heart disease, vascular risk, it's always better to be on thyroxine than not to be on thyroxine, depending on your vascular risk. If you're starting for marginal TSH for symptomatic benefit, if you're not feeling better at all with thyroxine, always you can stop the next visit and observe them in 3 to 6 months' time how their TSH is going to progress. So for subclinical hypothyroidism, there's no hard and fast rule, but it's going to be this long, depends on the clinical condition. And thank you for that question. It's a good question.
What if, in spite of large doses, still TSH remains high?
Yeah. So the commonest cause would be compliance. Then would be a brand issue. There's so many problems with the current brands we are using, and very few brands are working normally because heat has a lot of effect on thyroxine. How they store in pharmacies, at home, it's a lots of issues. So if you have a keep on high levels, don't keep on increasing your thyroxine levels. Make sure all the other factors are normal. And then we can think of any absorption issues. Then we give what is called a loading dose of thyroxine and we monitor their thyroid hormone levels. We do it in the clinic setup. That's what we can do if we think of any absorption problems. And next would be having any problems with patients with they factitious issues. They don't take it, but they keep on telling us they have done it for fear. Yes, but always there is a reason why the TSH is high, and we have to control them by finding the cause.
Is checking anti-TPO antibodies indicated in newly diagnosed primary hypothyroidism during pregnancy?
No, it's not a must, depending on the level. So the TSH levels, now the newer guidelines are coming up. I think this latest is still yet to be out in a few months, a few weeks actually, from ATA, American Thyroid Association. The guideline we have up to now say the TSH levels above 4, it is subclinical, we have to do the antibody. And if the antibodies are positive only, we start treatment for TSH above 4 in pregnancy. If your patient is pregnant, TSH less than 4, and antibodies, we still do that if it's closer to 4. And if the antibodies are negative, even if it is positive, you're not gonna treat this patient. So 4 above, you do the antibody. If it is positive, you treat. 4 below, if you have the facility, you can do and know what's happening, but you don't treat the TSH levels in pregnancy below 4 in the old guidelines up to now. 4 is the cutoff.
There is another
That's
question.
a normal person. Okay.
Can we start treatment for hyperthyroidism in primary care?
Of course. That's one of the best places to start because they would just go haywire looking for consultants. You can start, definitely do a T4 and T4 level, and if normal T3 level, get your diagnosis correct. That's very important. TSH, T4, you have it in full in book and record. This is where you started, and you can start carbimazole. You can continue treatment, and you can complete the 18 months of treatment as well. One of the indications to refer to a consultant, physician, or endocrinologist would be when you have problems in when they're having recurrences, if you're not responding to treatment, then you can refer. You can complete these 18 months of treatment at your practice.
Should the patient take the morning dose of thyroxine on the day of checking TSH levels?
It's a good question. Everybody asks about this. So the TSH levels, because we do only the TSH levels, we don't do T4 levels, and there's no implication of whether you have taken it or not for TSH. But it will be for if you're taking a T4 level. So when you take the thyroxine in the morning, it has an effect on the T4. So if your patient has taken both TSH and T4 against your advice, which we do not advise, then you can have a TSH normal and T4 higher because of whether you have taken thyroxine. So what I advise my patients is you take your thyroxine normal as usual and do the TSH levels in the morning hours. There's no particular time for TSH, but morning hours are preferred than the evening hours because there has a discrepancy levels between morning and evening in TSH, but not exactly timing as cortisol. But if you don't take it, you double the dose next day and do it. But that's only a problem if you are doing T4, not for TSH. You just ask them to drink your normal dose and go.
Can thyrotoxicosis in young patients be treated with radioactive iodine?
Yes. Anyone about 10 is recommended to have radioactive iodine. I have, I think, a dozen of patients about 12 years in having radioactive iodine. They go for the same protocol. If they do not respond to treatment, yes. Because I had a recent very bad encounter by the other way, the radiologist and the oncologist, where when we send for radioactive iodine, the patients were sent say, this is not the treatment for a young child. You can start more with treatment because it's a resistant thyrotoxicosis. The child should not go for surgery. They can offer radioactive iodine, which is very safe and very low risk for the patient. And there's no clear-cut data showing us there's a risk of malignancy in radioactive iodine treatment. They can have local tenderness, local problems, but nothing major at all. One of the safest treatments is radioactive iodine, and we can give it for children.
Is it necessary to take blood samples for TSH and T4 in the mornings?
Yes, morning hours are preferred because they can have there's a bit of diurnal variation in TSH, but not up to the levels of cortisol and growth hormone, which we don't do at all as a random sample because they're pulsatile. This is not pulsatile, but there is a diurnal variation. So morning hours are preferred, but there's no particular time for it. Morning hours. I would probably say before 10. Yeah.
There is another question, madam. If a patient has undergone radioactive iodine treatment, do they need lifelong thyroxine? If so, what lab tests are required for the follow-up, TSH, T4, or both?
So it's a good question. So after radioactive iodine treatment, the problem is in our country, we give 10 millicuries of radioactive iodine treatment for most patients. It's a dose for everybody. We don't measure the thyroid gland volume size. We don't have that facility to do that. That's how we correctly done. We should have a software to measure the volume and then we decide on the dose, which we do not have. It's the same dose for everybody. So it might be not enough, might be too much for the patient's particular gland. So we see both. We see the hypothyroid being happening, and we see not responding as well. The reason is the dose we give is what we give for all patients, 10. So if they become, not all patients become hypothyroid, we monitor them, and instructions are very important for these patients when they go for radioactive iodine treatment. We stop their the carbimazole 7 days prior to this radioactive iodine, and please recommence your your carbimazole after 7 days. But 14 days they should be without because it takes time for the radioactive iodine to work. It takes about 3 months. So you can't keep this patient toxic forever till it's going to work. So you start back after 7 days and you monitor your T4 levels as you've done before. And there'll be a time you will decide that your T4 levels are going gradually down. This patient is now going into hypothyroidism. You stop your carbimazole and you monitor whether it's transient hypothyroidism or going into permanent. You can't decide that initially because they tended to go down and gradually recover as well. So you observe these patients, stop treatment probably after about 3 to 6 months. You can stop carbimazole and some relapse, so you can't stop at all. You observe them, you monitor them in these patients. And if you detect them to going into hypothyroidism after stopping carbimazole, then you start on thyroxine. As I said, depending on the body weight, these patients are overtly hypothyroid. Depending on their body weight, 1.6 to 2 times the limit of their body weight. And we monitor with TSH afterwards, like we do in hypothyroid patients. We do not need T4, T3 after that once they are hypothyroid phase, right? So you must be seeing a lot of patients, Graves, radioactive iodine, now hypothyroid. So you just do a TSH and monitor. So after about 1 year of radioactive iodine, still if they have not recovered from hypothyroidism, it's very unlikely they're going to recover back. It's going to be permanent hypothyroidism. They'll be on lifelong treatment. And it's such a safe treatment than taking carbimazole and being toxic and be having a risk of heart failure, especially in an elderly. It's a very good option to be hypothyroid and take a replacement dose. That's how I advise my patients for radioactive iodine as well.
What is pseudohypothyroidism?
Pseudohypothyroidism comes in patients where a lot of obesity comes into setup and where all the symptoms are there of the obstructive sleep apnea symptoms, they're obese, they have symptoms of lethargy, but you keep on doing your tests and completely normal, TSH, T4, T3, and then these patients are just looking so much hyperthyroid, and you wish you could give a bit of thyroxine. Someone asks, can I give a bit of thyroxine and see their response? No, please don't do that. You need to have a biochemical, to be sure you're on the treatment, you have to have a biochemical hypothyroidism to start with. Don't treat for pseudo hypothyroidism.
Okay. What would be the management plan for a 12-year-old child with a visible and palpable goiter, thyroid enlargement on ultrasound scan, but no nodules, and normal thyroid function tests?
We just observe them. They're normal thyroid function tests because by giving thyroxine, we cannot reduce their goiter. That's been shown to be a failure of treatment. Sometimes you must have seen for even mild give goiters, some give thyroxine to reduce the goiter size, which is not needed at all. We cannot do that. There are structural problems. We treat the functionality with the thyroxine. So do not give thyroxine. Most are pubertal, even the growths, even just the mild enlargement, they come back to normal after the puberty sets in. So only observation, if your TFTs are even high, if the antibodies are negative, if the scans are normal, please do not treat.
How to diagnose and manage recurrent thyroiditis in primary care setting?
Yes, decoverage is a tricky one where patients come with pain, neck pain, fever, sometimes history of upper respiratory infections a couple of weeks back. So the treatment sets in depending on their thyroid function tests and symptomatic treatment. Most, like about 60 to 70% would be diagnosed by having ultrasound scan, which is showing heterogeneous echo texture, focal heterogeneity, not the whole gland is not affected, and they have vascularity being reduced. It's one of the important things. Vascularity reduced in the events. It's not increased like in Graves. You can do antibody level if you are really worried, which is Graves THS receptor antibody. But full blood count ESR will help us. It will be higher ESR, more than 16. Most patients with WBC showing a viral picture with high lymphocytes. That's enough for you to start treatment. And if in doubt, you do the TSH receptor antibody. Now, very rarely they can coexist, but not quite often as well. It's always Dicovent itself. So the first line would be to give them NSAIDs. Most patients recover just with NSAIDs, but they are having symptoms with high levels of T4 being released from the gland. You can start with steroids. We start with oral prednisolone or even sometimes methylprednisolone doses, and we always treat them symptomatically with beta blockers, and then together with NSAIDs. So NSAIDs for about 2 weeks and steroids for about 6 weeks, tailing off. Usually we start about 30 to 40 depending on the level, and each week we start reducing by 5. So you start 40, 35, 30 like that weekly. And by about 3 to 4 weeks, you can get them back with T4 and a ESR to see the response. And very rarely they can recover back the recovers, but not often. It's always just a one-time thing. And they go into triphasic hypo, don't treat with thyroxine, then it just goes back into normal. But you treat the toxic phase either with NSAIDs, with beta blockers, or NSAIDs, beta blockers, steroids all together if their levels are very high. T4 levels are very high. 3 to 4 times upper limit.
Okay. And subclinical hypothyroidism, even though we are not treated, does it increase? I think it asks about whether the untreated subclinical hypothyroidism increase cardiovascular risk. I think
It's an elderly patient. That's the reason we start there's reasons if you have patients in coronary heart disease patient, one of the indications to start thyroxine is that, but not in young patients. In elderly patients, yes, it increases the risk. So always better to start and explain to the patient, even if they're not symptomatic, we can start treatment with lower doses and make them euthyroid. It will definitely benefit them. Their dyslipidemias will get better, blood pressures will get better, and it has a benefit for coronary heart disease and elderly patients, but not more than 70. You have to be very cautious of the most elderly patients. Even at 70, you're not going to start treatment of a subclinical.
TSH level value. Okay. Can TSH levels be false positive with subclinical hypothyroidism?
Sorry, I didn't get the question.
Yeah, madam. It asks can TSH level values be false positive with subclinical hypothyroidism?
False positives I have not seen. So false positive means probably a lower TSH. I don't know. So for subclinical hypothyroidism, always the TSH should be upper limit of normal above 4 with a normal T4, T3. So there's no false positive. It always comes from a wrong lab report. Otherwise, no, you can't.
Okay, and the last question would be, what are the indications to do FNAC of a thyroid nodule?
It's always a thyroid scoring. So the thyroid scoring is one of the best scoring systems made available for us to decide on the fine needle aspirations. We just can't go and prick every nodule we see, because the micropapillary cancer management has revolutionized. Even they don't do surgery for micropapillary at the moment in some centers, saying that it's not going to progress. We're just going to wait and watch you. So because of that, the thyroid scoring systems comes in 1, 2, 3, 4, 5, and the thyroid scoring system itself gives us the risk of malignancy. It's kind of a separate lecture, I suppose. And the thyroid scoring above 4, even if the size is not decisive, there's a size we need to say you have to go to a for FNAC. It's more than 1.5 centimeters per thyroid. They look at the nodule, the risk of getting into malignancy. If the nodule is taller than the width, if you're having microcalcifications, increased vascularity in the nodule itself, and hypoechogenicity, lower than the normal thyroid, and irregular margins, they are high risk for malignancy. So depending on these features, they give the scoring system and say, this is a high risk nodule, you go for FNS. It's suggested by the radiologists themselves as well. So if the thyroid 2 nodules, say completely benign, they are cystic nodules, spongiforms, they are not malignant at all. They're very low risk. For thyroid 3 nodules, where they're indecisive, they say you monitor this only if the nodules are more than 2.5 centimeters. So they will give you the risk categories in these reports and say, I suggest FNAC, there's a high risk of malignancy. Unless you get that, don't do FNACs for all nodules. Just say monitor nodular goiter, just suspicious nodules. They have to monitor and tell us each nodule what the thyroid scoring is. Say they have 4 nodules, they have to say this nodule 1 is thyroid 1, thyroid 2, this is thyroid 3, this is thyroid 4. You do FNAC from thyroid 4 nodule, not from all the other above. So we have to have a scoring. You have if your radiologist is not doing this for you, you can request them. You have to request them to say, please do a thyroid scoring for this scan and tell us the risk of doing a FNAC or risk of malignancy for us. They just can't issue a report saying nodular goiter, no suspicious nodule. Sometimes even not even size is mentioned sometimes. We have to monitor this patient. So request a thyroid scoring system, because they are all very good radiologists and they will do it for you if you request. And in centers, like most tertiary centers, they do it now. They they give us a good report with the scoring system. Just read about thyroids. Very nice to know.
So I think we can wind up for today. So on behalf of our college, Sri Lanka College of Specialist Family Physicians, I thank you very much. I thank you, Dr. Dulani Kottahachchi. Thank you so much, madam, for your comprehensive lecture, comprehensive discussion, and it was so enlightening. And I would also like to thank my colleague, Dr. Deshan Kottagodalla, for coordinating you with us to do this lecture today. And thanks, I'd like to thank all the participants for your active participation by asking questions and answering questions. So your participation throughout the session was so useful. And before I conclude, I like to remind you to complete the feedback form, because your input helps us to improve the further sessions, and it is necessary to note your attendance for the CPD certificate as well. So thank you again, and we look forward to seeing you at the next CPD session. Have a great evening. Good night.
Thank you. Good night.